it's really must-have tools in the endovascular suite. So these are all of my conflicts that you just saw come through, and they really have, for once, really no impact on this talk. So what you need, you've already seen it from Jafar and a very nice talk from Gary regarding you can have everything you want on the shelf, but you don't need everything. You just need to have certain things and be able to do a procedure. Whether it's sexy or not is irrelevant. It's really how best to treat the patient at the least amount of cost to your center. So access tools, sheaths, wires, this is what this talk is all about. And from sheaths, you need to get in there and you need to maintain position. And it depends on what you like and who you have a premier account with. As long as you're with that group, it will work. It's a tube. As long as you get in and out safely, that's the most important thing. There's some differences, whether it's a destination sheath or a Rabi sheath. I think I left it up here. There is one sheath that we use a lot of. It's really from an unknown source. It's a named individual by the name of Ansel, but it's actually pretty good. And then you have various guide wires. You're going to use 035 guide wires. You're going to use 014 guide wires. You're going to have CTO guide wires. Whatever you use in the coronaries, whatever you use in the periphery, get used to it and start using it and work with it. Whether it's a workhorse or a commodity specialty, it becomes important to you. But you don't have to have 12 CTO wires on the shelf. You just need 1 or 2. You don't need 14 different glide wires on the shelf. You just need 1 or 2. So just kind of come up with what you need and then stick with it, and as you become facile with it, you'll grow. How to cross lesions, you're going to have things that are become important, whether it's antegrade, are you aficionado of always being true luminal? Can you tolerate a subintimal approach? How about transcollateral or retrograde? These are, kind of sexy these days, but not really terribly necessary in today's world in many cases. Reentry devices, you will go off the beaten trail, so you'll need 1 or 2. You'll need some CTO devices, but again, 1 or 2. The specialty devices to cross for luminal crossing or near luminal crossing may become important, but the problem with these devices is they're important up front, and you only need them when you fail trying to cross with a simple wire, so it becomes kind of this catch-22. So a stepwise approach, if you're unable to cross cleanly, look for alternatives. One would be try to cross antegrade. Here's simple antegrade crossing. If you can't cross antegrade and you find that you have a nice collateral bed here, you could probably make your way across that collateral and work retrograde. Again, fairly simple, but you just need a wire and a support catheter. Again, a commodity, not terribly expensive, and all you're paying for is really a stent. But if you can't get there antegrade, and you can always get there somehow, retrograde is a great opportunity. Whether or not you like to radiate your hands or not are irrelevant. And then you can go down the road of fixing up an artery, make it look pretty. But the key for all of this is limb salvage and patency. We always talk about limb salvage, but what's lost in the conundrum of science many times is the patency of what we have at the end. These retrograde techniques are really lovely. They look fantastic, but again, you have to have a mechanism to follow it, and you got to prove that you're actually doing some good for the patient, not just limb salvage, although it's very important. Once you get there, you got to have catheters to get you there and back again. Again, you got to be able to drive your car to and from work. So you got to have things that will allow you to transfer either wires or technologies over this system to allow you to get in and out of trouble. And whether or not you use something all the time, we like the old Spectranetics, now Philips systems, or you like Cook, it's irrelevant. They're all basically tubes that allow you to do your work. Once you get there, if you have to get off the beaten trail or you like CTO devices, whether it's the old Lumen device or the Outback catheter, have it on the shelf and get good at it, because you will need it in your practice as you move forward in time. The Outback, again, has been around since, when I was beginning my fellowship, and it's a very nice, very user-friendly device. It makes perfect sense. You line it up and you then deploy the nitinol hypotube needle, allows you to pass your 014 wire, and it gets you back into the lumen with the least amount of work. But again, this technology will cost you money, and it will affect your marginal costs. While you're doing your work, no matter how you look at it, whether you like to cut, shave, or just do plain old balloon angioplasty, you will have times with distal embolic debris. And so there is a myriad of devices now for distal embolic protection. Again, everybody and their cousin will make something. You don't need them all on the shelf, but you need to have something on the shelf. And from time to time, you will have to pull it. That will cost your margin. Whether you do atherectomy or not, or if you're in an OBL or not, it will cost you on your marginal costs. Balloons are a commodity, as Jafar said, and really what's critical to balloons, if you ever lived in the coronary world, we had to learn when I was a fellow the workhorse balloons, which were very compliant, then you had semi-compliant and then non-compliant. In the peripheral world, all of these devices are almost invariably semi-compliant, which simply means they grow. But what does that mean, that they grow? What they have is differential expansion. You have to remember that there's resistance to expansion, and then there's least resistance to expansion. And where the balloon will expand or grow is in that least resisted area. And so you'll get differential expansion, which leads to dissections and potentially perforations. But some of the devices that we have, the Dorados or Conquests, are non-compliant. They're made out of Kevlar, so when you dilate them up and they go to the certain size, and they're always going to be that size, so they can crack fairly resistant or recalcitrant lesions. And both styles can go to high pressure, but you have to note the rated burst pressure in any balloon. And most devices, even today's 035 devices, are almost invariably exceedingly deliverable, much more so than they were in the past. So when things just don't get you there, you're really going to need some help. There are a whole bunch of specialty devices that are made specifically for crossing CTOs. The Viance or Antier has a 150 centimeter working length, 5 French sheath compatible. Basically spin it through and try to find a luminal passage. The Off-Road or True Path, 100 centimeter or 70 centimeter working length, 6 French compatible, hypotube with a center balloon, which tends to try to direct you towards a lumen. It gives you a distal push, which is, in many cases, several fold in gram strength higher than you would with just a wire. The Roxwood device, which was just sold, is 125 centimeters and 6 French compatible, fairly intriguing nitinol cage to help you center. Every one of these devices, if you think about them, they all presume center location, design center location for lumen, when in many cases that lumen may not be straight away from you. The Cruzar, which is a Houdini device, is an invaginated balloon. Again, it pushes out, invaginates a balloon out, and allows the wire that's entrapped in it to be then expressed at a 2-to-1 metric on distance. And again, idea is that it maintains luminal position. And then the Crosslock, which is from Radius Medical, 125 centimeter working length and 6 French sheath compatible. Again, something that will allow you to maintain a luminal position as you try to go forward. And then the Avenger device, the Ocelot device using OCT technology, tries to maintain a intimal medial position rather than towards the adventitia. Pedal access tools, a whole bunch of various devices which can get you into a lumen distally. The Cook system is pretty much the ones that we use a lot of. It's a check flow valve for a French device, but larger sheaths have been used in the lower extremity to get you retrograde pedal access. And in many cases, the support catheters here are now dedicated to pedal access and support in these fairly non-forgiving arteries. But you could take an artery like this, which is a termination of a perineal artery trying to revascularize a limb, and come around and actually use that as a conduit for retrograde pedal, meaning through the transcollateral, and then work antegrade to work around the pedal arch. And you've already seen this picture with the revascularization of the tibials. One other thing that you will have to have on your shelf is thrombus aspiration. Almost invariably, every one of these is a big straw. They just aspirate, that's all you're doing, and everybody and their cousin will make one. Find one that you like and use it. There are various tip strengths and various tip loads, but at the end of the day, it's just basically a 5 French catheter, and it goes downstream and you try to aspirate what you've embolized. There is a need for rheolytic thrombectomy. There's still power pulse spray. The only way that Angiojet has maintained its position in this world is in the periphery after the AMI trial fell flat in the coronaries. And it's a pretty good device. They now have a myriad of devices, small, medium, and large, to get you there. But there is various competitors which work very well, one of which is the Penumbra device, basically a big tube that goes to a suction vacuum, and you basically agitate the hell out of the thrombus, and you basically break it up and aspirate it into a big tank right there, and it works. It works very nicely, even in subacute thrombus. So in this non-sexy talk, I apologize. These conclusions are fairly straightforward. Devices and selection of method of intervention remain at your discretion. It's always going to be up to you. You can make it as expensive or as least expensive as you want. Access and contemporary interventional approaches really allow a myriad of technologies and devices for ultimate revascularization. And the issues that remain is that we may still be too aggressive in the pedal arch. I really have a hard time believing mucking around down there is going to be good all the time, but if you can get away with it, it works. All devices are available, and you need to pick one or two and become facile with any one of them to actually have a fairly productive and good program and cost-effective program in your hospital. And understand the primary, and then follow it up with your backup approaches when any of those primary approaches failed in any one interventional case. Thank you.